corneal thickness, cornea, corneal biomechanical properties, all are essential as far as measuring IOP in any form is concerned. And we all know IOP is the only modifiable risk factor for glaucoma. Hence, corneal thickness, IOP, and glaucoma have a close association with each other. Racially, African Americans have thinner corneas compared to other races, and even physiologically, there is enough diurnal variation where you see thicker corneas in the morning and also in contact lens users. Goldman applanation tonometry, which is the gold standard as far as IOP measurement is concerned, is based on the invert fixed law, which we all know assumes the cornea to be infinitely thin, perfectly flexible and elastic, which it is not, and hence it is fallacious. Goldman and Schmidt postulated that for a corneal thickness of 520 micron, all the forces of the cornea sort of counteract each other when the applanating diameter is 3.06 millimeter. But we all know, again, there's tremendous variation in corneal thickness, all the way from 450 to 650, and even from center to periphery. So this always does not necessarily hold true. Why is CCT so clinically important? This is important because all our major glaucoma landmark trials, and especially the ocular hypertension treatment study, clearly told us that subjects with a reduced, for almost a 40 micron reduction of CCT, the risk of developing primary open-angle glaucoma is almost 70% more. Eyes with CCT less than 555 microns were at least 3 times more likely to develop glaucoma as compared to 588 microns. And with correct use of CCT, there's reclassification of disease from normal-tension disease to primary open-angle glaucoma, and even from ocular hypertension to normal eyes. There are different techniques by which we measure central corneal thickness. Gold standard is the conventional or the contact ultrasound pachymetry. There are also other non-contact methods, OCT, pentacam, etc. We just look if there's any difference. As I said, the ultrasound pachymetry is gold standard, inexpensive, good reproducibility and repeatability. However, it is expert operator dependent and requires good precise probe positioning. Studies have shown us almost a 15 to 20 micron inter-observer variation. In association with this, you also have non-contact devices like optical biometers, Scheinfeld camera-based systems like the Pentacam, which also give very good, reliable corneal thickness measurements, however, slightly overestimated, but can be used interchangeably. So why is CCT and glaucoma important? Because as I said earlier, Goldman's is the gold standard. We know there are fallacies in measurement of IOP using the Goldman's. We know that thick corneas overestimate IOP, thin corneas underestimate IOP. So what IOP we are getting on GET, is it a true IOP, or do we need to correct it to get the true IOP? And if yes, is there any ideal formula? So if we look at the various tonometric correction formulae of the ages, you have the Ehlers, Whittaker, the mathematical model of the Ozengo pi, the Doty, and let's look at the Ehlers, which was the first one to give us a nomogram for an adjusted IOP and CCT value. For every 10 micron change, it suggested 0.7 millimeter mercury change. So if it's thicker, you subtract. If it's thinner, you add. And for a 25 micron change in the CCT, it suggested 1.75 to 2 millimeter mercury. Along with that, you had the Dresner as well. For a 25 micron deviation, it suggested 1 millimeter mercury. And the Doty's meta-analysis told us that for every 10% change of corneal thickness, you need to change the IOP by 3.5 millimeter mercury. So you have 1 millimeter, 2 millimeter, 3.5 millimeter mercury for similar changes in corneal thickness. Which one do we use? The answer is none, because studies, literature clearly showed us that adjusting IOP for central corneal thickness does not improve your prediction models for open-angle glaucoma. In fact, using Ehlers nomogram may increase your error of getting the correct IOP value, taking you in the other direction rather. And even the mathematical models of Ozengo pi do not really give us anything in the IOP compared to what we normally get. So this was all summarized by the World Glaucoma Association consensus, which clearly said, in conclusion, no generalized correction nomogram can ever adequately adjust IOP without knowing much more or much less about the individual cornea being applanated. We may be in the wrong direction and by quite often quite a bit as well. Most of our normal IOP measuring devices, whether it's the GAT or the tonopen, pneumotonometer or the NCT, all are significantly associated by the central corneal thickness, with the NCT or the non-contact significantly being more compared to the Goldman's applanation tonometer. However, the Pascal's dynamic contour tonometer is the least affected by central corneal thickness when it comes to IOP measurement as compared to Goldman's as well, because it does not use the principle of applanation, but it uses the principle of contour matching, where the DCT head sits on the surface of the cornea, does not applanate it. The sensor in the sensor picks up the limbal stretch, and you get a numerical IOP value, which is least affected by CCT. Hence, what I really feel is that the DCT would be definitely the tonometer of choice in eyes which have undergone a refractive surgery because of the large amount of corneal thinning produced by the ablation there. Just a quick word on the new kid on the block, which is corneal hysteresis, which is nothing but a measure of the corneal viscoelasticity and the biomechanical property of the cornea. The ability of the cornea to undergo a change when it is put through a deforming force, and its ability to come back to its normal shape is what is the compliance, which is nothing but the hysteresis. It is measured by an instrument called as the ocular response analyzer. Just an air column is thrown onto the cornea applanates inwards. We get an applanation pressure 1, and when the cornea comes back to its position, we get an applanation pressure number 2. The difference between two is the corneal hysteresis, which is noted to be low in POAG and patients with NTG, and also significantly eyes with low corneal hysteresis have been shown to have worsening of the visual field damage. So other quick considerations: eyes with low CCT have lower RNFL but not too sure. As far as systemic and ocular factors remain constant, a reliable and well-taken CCT remains valid for at least 3 years, as per Dr. Vijaya's paper in 2013. And for CCT and post-refractive eyes, there is no particular correction formula. So my take-home or take-clinic message is what I heard last week is CCT an important test? Yes, for any and every patient. Serves as a very important guideline in assessing target IOP. Ultrasound pachymeter is easily available, cheap, reproducible. No need to correct IOP with any formula, and there's clear evidence for that. The Pascal's DCT may be the instrument which is least dependent on central corneal thickness, and we need not repeat CCT if taken correctly for at least a period of 3 years. Thank you, and I think I'm on time.
Thank you, wonderful. That's excellent, actually. And could I please have Dr. Rajendra call our third speaker? Dr. Rajendra? Okay,
Dr. Manjari is the third speaker.
Dr. Manjari, yeah.
Dr. Manjari,
Dr. Manjari, she's going to talk on combined cataract and glaucoma surgery, 2 separate ports.
All right.
Is my screen visible?
Yes, ma'am, but you need to go to the beginning of your talk.
How do I go back to?
You just click home. It will start from the beginning.
Is the slide visible?
No,
No,
they are not visible. Right, yeah, on the right side, bottom, madam, press that, share the screen.
Green one, no?
Yes, ma'am.
I have already clicked on that.
Yes, ma'am, you can start it.
Is it seen?
Yes, ma'am.
Yes, that's fine.
Yes, now it's fine.
Now coming.
Yes,
Yeah, you
madam.
can start. You can start.
Madam, you can start.
Please start.
My talk is on combined surgery, glaucoma and cataract,
Yep.
2 sides approach. My usual approach is superior side for glaucoma procedure and temporal one for cataract one. Cataract is usually done from temporal clear corneal tunnel incision. Incision size differs from sub to like 1.8 to 2.8 millimeters. You can combine it with temporal SICS also, and the choice of size of incision depends upon the grade of the cataract. Usually after finishing the cataract procedure, I close the incision by Teno nylon. The advantage of this is that in early post-op phase, it allows digital pressure massage to manage bleb, and it reduces the chance of inadvertent entry of anti-metabolites into anterior chamber. Here, if we take two separate approach, you can choose premium IOLs and you can better manage the astigmatism part of it, because temporal cataract incision induces small amount of with the rule astigmatism and being advantage in most of the patients who have against the rule astigmatism. You can combine it with SICS also with temporal scleral tunnel incision. Commonest glaucoma procedure is trabeculectomy. My preferred site is superior site for the surgery. Here the advantages are bleb is well covered with upper lid. There is no phaco disturbance by phaco incision. We have a better control on both the surgeries because even though they are done simultaneously, you have a they are separate procedures done simultaneously but from two sides. uh, Flap choice is usually conjunctival or fornix based. My choice is fornix based flap. Here, then anti-metabolites are applied. Cataract incision is closed, which reduces the entry of anti-metabolites, and MMC of desired concentration is applied, and then it's thoroughly washed with ringer. Superior scleral flap, size, shape, and site is customized because you have total superior site to manage this according to the grade of glaucoma and choice of surgeon. Inner scleral flap, in case of non-penetrating glaucoma surgeries like deep sclerectomy, viscocanalostomy or canaloplasty is taken after this. And then in case of trabeculectomy, inner scleral block with trabecular meshwork to de-roof Schlemm's canal, size and site also can be customized at 12 o'clock. And for NPGS also, this superior approach is desirable because Schlemm's canal width is widest at this position. Then EBI is performed through the scleral window. And in case of NPGS, this step is not done because there is direct communication between the anterior chamber and the filtering blade through Desmet's window. It is a site for aqueous percolation with relation to the pressure gradient between anterior chamber and the scleral leg below the superior scleral flap. Other procedures you can combine with are express shunts and trabeculectomy with collagen implant. Other ab interno NPGS, MIGS procedures also can be combined. Here the trabeculoplasty with trabectome is done at the superior site when you finish off your phaco surgery. Glaucos ab interno shunt can also be combined with temporal phaco. Then glaucoma drainage devices, non-balled and balled implants also you can combine with phacoemulsification. Technically, releasable and adjustable sutures are easy, and postoperative management is easy if the site is different from your cataract operation. Early postoperative bleb management at the site of scleral flap, if you want to do digital massage, it is easier if you have a separate site. Postoperative IOP control is almost equal in both single and two-port surgeries. Cataract surgeries, usually when cataract is associated with glaucoma, you have some intraoperative difficulties like small pupil, floppy iris syndromes, posterior synechia, complicated cataract, or pseudo exfoliation syndrome can be managed better if you have a separate port. Astigmatism management I was already talked about, and other premium IOLs, and if you want to combine with LRI, that also can be planned better if you have two sides approach. Here I have two videos. One is with deep sclerectomy with phacoemulsification. Do I have time?
You have 2 minutes. 2 minutes, madam. 2 minutes.
Here the site of glaucoma surgery is superiorly. Here I have finished taking the flap and superior scleral flap. Now I am dissecting the deeper one. Now I am going towards this thing, Schlem's canal. Here, while deroofing, taking the deep flap, the deroofing of this happens. But there I stop before going to cataract surgery. Here, decompression of AC is important in when you manage glaucoma with cataract. Here I finish off my phaco surgery and then again come back to my glaucoma surgery. Phacoemulsification is being performed. This deep sclerectomy surgery is done along with this thing. I have one more video of combining it with trabeculectomy.
30 seconds, madam.
Oh. It will be over. Here the deroofing of the Schlem's canal done. This is a flap trap with trabeculectomy. After finishing cataract surgery, corneal traction suture is taken. Again, fornix-based flap. Mitomycin C is applied. Then this is scleral tunnel, the way you take it for SICS. No vertical cuts are taken in this type of flap trabeculectomy. Entering into AC.
1 minute to 1.
And almost done.
You know, we're already 9 minutes late in the session. That means that, you know, one
Almost
talk
done.
is going to be left out
Done.
actually.
Almost done. And here I complete my trabeculectomy.
Okay, I think we should move on to the next speaker.
I'll stop
because
now.
Because we're really, you know, 9 minutes late now and we won't be able to finish the session.
It's already over.
Very unfair to the speakers actually.
I'm already done. Thank you.
Thank you.
Thank you, ma'am.
Okay, maybe call on Dr. Swapnil Kothari. He's going to talk to us on, you know, newer or upcoming medications in glaucoma and the appropriate position. Swapnil, you're going to promise me that you're going to stick to 8 minutes or less,
Yes,
or
sir.
otherwise you switch off the video when Mayab says that your time is up actually.
Yes, sir.
All right?
Yes, sir.
That's the condition that you're coming online.
Yes, sir.
All right.
Good morning, and I would like to thank BOA as well as MOS for giving me the opportunity to share my talk. My talk is on upcoming medications in glaucoma and their appropriate positioning. We have no financial disclosure. Glaucoma, as we all know, is an optic neuropathy with high IOP being the one of the predominant factors and actually the only easily modifiable factor that we have. I hope my screen is visible.
Yes, it is.
Yeah.
It is.
Target IOP is basically the thing we achieve, we plan to achieve, and it is determined on a case-to-case basis and modified at intervals as per need. We have different algorithms given by AO as well as by the European Glaucoma Society, which helps us to tailor-make a target IOP for a particular patient. We have a lot of options as far as glaucoma medications are concerned, but still we need more because many patients who come with severe damage or low baseline IOP need a very low target IOP, which may not be available, which may not be possible to achieve with current medications. There may be systemic contraindication to the medication. There may be intolerable ADRs or insufficient response, as well as the incisional surgery that might be required in these patients carries its own inherent risk, with the risks of high risk of failure due to local factors like congenital scarring, etc. And the patient may not be fit, since most of our glaucoma patients are significantly elderly population. Currently, we have beta blockers and carbonic anhydrase, etc. In the newer drugs which are in the pipeline, which are latanoprostene, Binod, ripasudil, netasudil, as well as few implants, which I'm going to discuss in this talk. ROCK inhibitors is going to be taken care by Dr. Ashish Thool, who's the next speaker. So I'm going to skip over that part for this talk. Coming to latanoprostene Binod, this is a nitric oxide donor as well as a prostaglandin F2 alpha analog, which has received its FDA approval in 2017. And it has convenient once daily dosing. And efficacy wise, when you compare the efficacy of latanoprostene in fact, for all prostaglandin analogs, bimatoprost 0.03% sits at the top with an average reduction of 5.59 millimeters of mercury from baseline. So latanoprostene Binod, it is not available in India, but it actually is efficaciously comparable to bimatoprost 0.01%, followed by tafluprost, latanoprost, and tavaprost, which are more effective as compared to brimonidine, timolol, and onoprostone. The second drug which is in the pipeline, which has been approved in Japan and South Korea, is OMDI. It's a selective non-prostaglandin prostanoid EP2 receptor agonist, and it has been shown to be non-inferior to that of latanoprost, however, has significantly more ADRs as compared to the same. Coming to the implants, we have this again is not available in India right now, but it is an FDA approved implant, sustained release glaucoma implant, which carries 10 micrograms of bimatoprost. And it's a rod-like biodegradable implant available on a sterile 28 gauge delivery system. This implant is supposed to sit in the inferior iridocorneal angle, and on-label efficacy is for around 4 to 6 months, though action is being noted during the studies to last for a longer time. What are the pros? Durasta is a bimatoprost or sustained release implant. So what are the pros we're looking at? Basically, since it's in the anterior chamber, there's no ocular surface toxicity. It is compliance independent. It has been shown in the studies to be non-inferior to bimatoprost topically, as well as doesn't have the side effects of eyelash growth as well as PGA associated periorbitopathy. Cons, not available in India. Cost might be more. There is always a theoretical risk of endophthalmitis when we are talking about any intraocular procedure. Since this sits in the inferior iridocorneal angle near to the cornea, there is a small risk of endothelial cell loss, and hence that has been approved for a single use. Though people are using it off-label in multiple use case scenarios. As with all prostaglandin analogs, there is a risk of CME, and there is, since it is a non-anchored implant, there is a risk of implant migration. This is a small video of how the Durasta injectable system is. This is basically similar to Ozurdex cartridge, where you have a cartridge and the Durasta is already loaded in that, and you just go into the anterior chamber and release the implant in the anterior chamber. We can see the implant resting here, and you ask the patient to sit up for about an hour, and the implant is going to go and sit into the inferior iridocorneal angle. Sorry. These are the serial gonioscopic follow-ups of Durasta, in which you can see the Durasta sitting at 2 weeks at the inferior iridocorneal angle, and by 12 months it has reduced by about 80% of its size. The second implant that is in the pipeline currently in phase 3 is iDose. This is made by Glaucoma, which is the same company which provides with iStent. So they have a vast experience in making these implants. This is a 1.8 by 0.5 millimeter biocompatible titanium implant, and it is sustained release trabectopros for 6 months or longer. At the end of its efficacy, you can take it out and put it, replace with another one. This is basically the implantation mechanism is similar to iStent, where you actually form the anterior chamber with viscoelastic, then go through the main incision and anchor the implant at the trabecular meshwork under direct visualization with direct gonioscopy. So this is basically how you implant the iDose. Another one which is in the pipeline is Travoprost XR, which is codenamed ENV515. Right now it is in the phase 2 clinical trial. Difference between this and iDose is it's a fully biodegradable intracameral implant, and they are targeting a 1-year dosing, while iDose as well as the hematoprost implant Durasta are targeted at 6-monthly dosing, and it's showing a mean reduction of 6.7 millimeters of mercury. These all three of them are intracameral implant and require the eye to be opened in the operating theater, while the next two implant, that is OTXTP as well as Evolute, which is these are basically punctal plug delivery systems, in which we can see that the implant is sitting in the punctal plug and it has fluorescein in that, which you can just show a blue light onto that to show you that it is sitting properly at its closed position. It is a slit lamp non-invasive insertion. This is a PEG-based hydrogel with embedded trabectopros loaded microspheres, and duration of action is approximately 3 months. Another honorable mentions are bimatoprost and bamosiran, which is a small interfering RNA phase 2 trial completed drop. Coming to the position of these implants and drugs in our armamentarium, coming to Rho kinase inhibitor, as we will be seeing in the next talk, these are not the first line drug due to their high ADRs. They can be used as an adjunct to patient on uncontrolled maximum medical therapy and as a substitute to other AGM in case the patient develops ADRs related to them, for example, a brimonidine hypersensitivity. Latanoprosin, Bunod, and OMD, basically these are another options for PGAs, and as we all know, PGAs allow us to change the drug within the group, expecting the other option in the same group to give some better result than what we are getting. We can replace latanoprost with latanoprostine, we can replace bimatoprost with trabectopros, etc. Durasta, iDose, and ENV515, they are basically for those patients who have poor ocular surface and are incompliant to topical AGMs as an adjunct to cataract surgery and poor compliance to topical therapy, and similarly we can expect for the intracanalicular plugs.
8 minutes.
Thank you very much. I'm done. These
Thank
are my
you,
references.
Swapnil. Yeah, that was right on time. And may I have the next speaker? That's Dr. Ashish. Dr. Ashish Thul is going to talk to us on Rho kinase inhibitors.
Thank you, sir. At the outset, would like to thank the BOA and MOS for the invite. And friends, Rho kinase inhibitors or ROC inhibitors have created quite a buzz over last few years. We'll be talking about their indications in ophthalmology, the mechanism of action for these indications, the available options that are there for us today, the data from clinical trials telling us about its efficacy and adverse effect profile, and lastly, where do we actually place them in our clinical practice. So ROC inhibitors have been proposed to be useful in glaucoma, corneal endothelial disease, and diabetic retinopathy with macular edema. In cases of corneal endothelial disease, whether we use a topical drop or we use the ROC inhibitor along with cultured endothelial cells as an intracameral injection, they will basically decrease the cell adhesion, endothelial cell adhesion, and also increase the endothelial cell apoptosis, and increase the cell adhesion along with increasing the cell proliferation, thereby improving the endothelial cell density and clearing the cornea. They have shown to be useful in Fuchs endothelial corneal disease. A small case series of endothelial damage after cataract surgery did show on use of ROC inhibitor eye drops, recovery in corneal transparency and increase in endothelial cell density. In cases of eyes with diabetic retinopathy, you either use an intravitreal injection or an implant, which would actually decrease the creation of anchor sites for the leukocytes to adhere to the retinal microvascular endothelium layer, and then In addition to this, it will also slow the microvascular endothelial damage in the retinal vessels by reversing the endothelial nitric oxide synthase activation. These basically have been studied in the diabetic rat models. So for diabetic retinopathy, is there any role of eye drops? Well, a small case series did show that there was some decrease in the central foveal thickness, but it was not associated with concurrent improvement in the visual acuity. So for glaucoma, it has established itself in various clinical studies as good IOP lowering agents, although the lowering is quite modest. And in lab studies, it also has shown some effect as an anti-scarring agent. So basically, it will increase the aqueous humor outflow by working at the level of trabecular meshwork. Both the ripasudil and netarsudil molecule mainly work by increasing the aqueous outflow. In addition to that, netarsudil will also reduce the aqueous production and decrease the episcleral venous pressure. So Rho kinase pathway inhibition will lead to change in the cell shape and actin cytoskeleton structure. What this means that this would kind of widen the trabecular meshwork beams and allow for greater outflow to the trabecular meshwork. In addition to this, with netarsudil, which is also a norepinephrine transport inhibitor, it will lower aqueous production and episcleral venous pressure as well. So ripasudil was approved in Japan in 2014 by the brand name Glanatec, and it is available to us since almost 1.5 years now by the brand name Ripatec, 0.4 concentration, and the preservative is BKC. It has shown to lower the intraocular pressure from baseline IOP by 4.5 millimeters of mercury at 2 hours after instillation, and this effect was seen over a period of full 1 year consistently. The most common adverse effect is conjunctival hyperemia. You can see more than 65% of the individuals show that, followed by conjunctival or subconjunctival hemorrhage, which is dose independent. It is also shown effect as an adjunctive agent whether you add it with a beta blocker like timolol or latanoprost, or even in patients who are having maximally tolerated medical therapy, it does show some additive effect. Whereas in secondary glaucomas, ripasudil has shown to be effective in reducing IOP in uveitic glaucoma, exfoliative glaucoma, as well as steroid-induced glaucoma, and additional benefit in uveitic glaucoma in the form of significant decrease in AC cell score also has been seen. Netarsudil was approved by US FDA in 2017 by the brand name Ropresa, 0.02% concentration. The same is available to us by the brand name Netalo since over 6 months now. The rocket trials on the basis of which netarsudil got the US FDA approval basically are phase 3 clinical trials which investigated safety and effectiveness relating to netarsudil and timolol in patients with elevated intraocular pressure. And the pooled efficacy data tells us that whether at baseline IOP of less than 25 or less than 30 millimeters of mercury, once daily dose of netarsudil was found to be non-inferior to twice daily timolol molecule at all 9 time points throughout 3-month period, and the IOP reduction from baseline was in the range of around 4.8 to 5 millimeters of mercury respectively. The systemic adverse effects not so great, minimal treatment related serious adverse effects. Ocular adverse events, most common, over 50% of the individual eyes had conjunctival hyperemia, 6% discontinued the drop because of that. Over 20% showed corneal verticillatus. This is world keratopathy, similar to what you can see with patients who are on amiodarone therapy or sometimes with topical tobramycin also. There was conjunctival hemorrhage noted in 17.2% individuals. One interesting ocular adverse effect not noted in US FDA trial is this reticular bullous epithelial edema in corneas treated with netarsudil. Most of these patients had a history of risk factor of corneal edema. That means the corneal endothelium was already compromised, and these did tend to reverse after stopping the drug after a couple of weeks or so. This is how it looks like. We have seen it in 2 patients in our limited experience. This is one fixed drug combination that we are waiting for by the brand name Rocklatan. It is already US FDA approved in 2019. It is not yet available to us in India, because it is a fixed drug combination, has a very good IOP reducing efficacy of less than 16 millimeters of mercury. Over 58.4% of eyes were able to achieve that, and over 30% of the eyes achieved at least a 40% reduction. So again, no treatment related serious adverse event, and the ocular adverse events basically would be same as what you would expect with the individual molecules, right? And in clinical practice, now we would want to use with the data that is available with us for corneal endothelial disease. Maybe we can use ripasudil for Fuchs corneal endothelial dystrophy and maybe early PBK. There's no data to support the role of topical Rho kinase inhibitors for diabetic retinopathy and macular edema. And in glaucoma, because of its modest efficacy and the side effect profile that we have seen, we would mainly want to use it as an adjunctive treatment, whether in primary open angle glaucoma, ocular hypertension, steroid-induced glaucoma, or secondary glaucomas. In uveitic glaucoma, you can get an added benefit in the form of reduction in the inflammation. All these type secondary glaucomas or even angle closure glaucoma that we are talking about, whether there is a synovial angle closure or whether there is a dysfunctional trabecular meshwork as in angle recession glaucoma, depending on how much amount of trabecular meshwork is either blocked or is dysfunctional, this may or may not work. The drops may or may not work. And same is the case with neovascular glaucoma. If the synovial closure is almost complete, it really will not work. As an anti-scarring agent, it does seem to have some potential, but we need further evidence from clinical studies. So to sum up, ROCK inhibitors, both ripasudil and netarsudil, are a welcome addition to our therapeutic armamentarium, especially in relation to glaucoma. They have a definite role to play, but mainly only as an adjunct therapy. We cannot use it as a primary line of therapy or monotherapy because of the modest IOP lowering efficacy and reasonable safety profile. It does seem to have a potential to be useful as an anti-scarring agent. Thank you so much for a patient here.
Thank you very much, Ashish. And I hope there will be a few minutes left to field some questions. And may I go ahead, Shefali, with the talk?
So our next speaker is Dr. Vinay Nangia, and who is going to talk on the maximum medical therapy and its implication. Yes, sir, Dr. Nangia.
Okay, yeah. Is it being shared?
Yes, sir.
Okay, all right. So I'm going to take you through some slides on maximal medical therapy, and please remind me at 7 minutes, Mayav. And it's important to understand not only the aims of therapy, but also the mode of action, side effects, and contraindications to each individual medication. So as far as the guidelines are concerned, the European Glaucoma Society guidelines stated that as a rule, medical therapy should start with one drug. And they also stated generally if more than 2 topical medications are required to control the disease, then other forms of therapy such as laser, trabeculectomy, or surgery should be considered. So I think this is an important concept in what constitutes maximal medical therapy, because that's the threshold when you move into the zone of doing laser or considering surgery. In India, the use of laser trabeculectomy is rather limited compared to our Western colleagues. And in most instances, ophthalmologists in India prefer to add a 3rd or 4th medication and then tend to go for surgery following inability to reduce intraocular pressure. So what's the pressure reducing efficacy? When we start, let's say with beta blockers, they have a 20 to 25% pressure reducing efficacy. Pilocarpine is somewhat similar. Systemic acetazolamide is also somewhat similar. Alpha-2 agonists are also somewhat similar, but prostaglandins have a much higher pressure reducing efficacy that can go up to 35%. And topical carbonic anhydrase inhibitors have a somewhat lesser pressure reducing efficacy. And this is all to some extent based on the starting intraocular pressure. So the primary drug is most effective. It has a pressure reducing efficacy ranging from 20 to 35%. The first add-on is less effective. The second add-on is least effective. So you're using 3 medications now. So it depends on at what level you're adding the second or third medication, and that will depend on the efficacy in that particular patient. So with monotherapy, a 25% reduction may be expected. From 2-drug therapy, 35%, from 3-drug therapy, maybe 40%. And this is all based on the starting naive intraocular pressure, that is the pressure that the patient presents with actually. So this is a patient with an intraocular pressure of 30 millimeters of mercury. Let's say we had a target pressure of 15 millimeters of mercury. So we might start with prostaglandins. We might achieve a pressure reducing efficacy of 30%. Then we add beta blocker. We get another 2 to 3 millimeters pressure reducing efficacy. And then when we add alpha-2 agonists, then we may not expect more than 1 to 2 millimeters additional pressure reducing efficacy. So you already know to a certain extent as to where you are headed when you're adding the second and third medication. So this is a patient on maximal medical therapy, and his status post-TRAB. Intraocular pressure is 13 in the right eye and 18 in the left eye. And this patient is on 4 anti-glaucoma medication. This is another example where we have a CD ratio of 0.5 is 0.6. And even though the OCT was normal, the retinal nerve fiber layer was normal, the intraocular pressure was 18 and 19 millimeters of mercury. So this is just an example from literature of combination therapy, that when you have, if you start with untreated baseline of 28 or 29, you add travoprost, you reach about 22, you add timolol to the travoprost, you reach just a little below 20. And when you add brinzolamide, then it might bring you to about up to about 16 or 17. So this is roughly what I had described earlier in the talk, actually. We analyzed in our hospital, actually, and we said that all subjects using 2 or more medication, either eye, were considered to be on maximal medical therapy. And we studied 91 eyes of 64 subjects. The mean age was about 60 years, and the mean number of anti-glaucoma medications was 2.6. The mean intraocular pressure in these subjects was 23.4 millimeters of mercury. So there were 42 eyes with 2 medications, 40 eyes with 3 medications, and 8 eyes with 4 medications, actually. And there is a sense from previous studies, and we'd like to ask whether there is a correlation of the number of medications with the duration of glaucoma or of treatment. That is, do you start increasing the number of medication with time, or that is with the duration of glaucoma or with the duration of treatment, actually? So we found that at our hospital, we were using a combination of alpha agonist and beta blocker in a larger number of eyes. But of course, there were several other variations of drops that we were using. And there were almost 12 or 13 variations of combination therapy that resulted in maximal medical therapy that we were using. So of the 91 eyes, only 26 eyes did not undergo surgery and 65 eyes underwent surgery. That's an important indicator to us that when you're reaching maximal medical therapy, that you may assume that a majority of your patients are likely to undergo surgery. So you start preparing for that in that sense, actually. And so the findings from the study are that a large majority of eyes tend to be on 2 or 3 glaucoma medications. Based on clinical parameters and in the Indian subcontinent context, even 2 medications may be considered as maximal medical therapy for many, many reasons. And many patients therefore tend to be on maximal medical therapy. In view of a large number of anti-glaucoma medications available, there appear to be any number of combinations that one uses. But it may be better to have guidelines and protocols for which combinations may be used in a particular practice, in a particular institute, for maximal medical therapy to create a relatively uniform treatment paradigm for better data and understanding. A majority of patients on maximal medical therapy tend to undergo surgery. These patients therefore need to be watched and followed up more carefully, especially in regard to their compliance and structural and functional changes, actually. So what is MMT? It is the maximal therapy that may be applied for a particular patient. One may be cautious in assessing the efficacy of the 3rd or 4th medication. Restricting maximal medical therapy to 2 medications is based on visual function and quality of life of a particular patient, and so is the decision to do surgery after the use of only 2 drug therapy in such patients. The use of 3 or 4 drug therapy should be eminently justified in our clinics, using our experience to ensure that it is actually beneficial. Thank you all very much for this hearing. Thank you.
So thank you, Dr. Nangia, for such a wonderful overview about the maximum medical therapy. I think there is always a lot of confusion whether to add or whether to do the surgery. And now our next talk is Dr. Lipi, who is going to talk on the management of failing bleb. I think failing bleb is a nightmare for all the glaucoma surgeons. So she'll be talking on the management of failing bleb.
Yeah,
Dr. Lipi.
Yeah, good morning all. So after all this medical potpourri, I move on to a surgical topic. My presentation is on management of failing trabeculectomy. Right. So I hope that the slide is visible.
Yes, yes, Dr. Lippi, please go
Right.
on.
So I have no financial interest here. So how do we manage a failing trap? First and foremost, we need to recognize that the bleb is failing. Second, we need to identify the cause. Third and fourth, they form part of the treatment wherein we deal with the rising intraocular pressure and try to restore the bleb function. So these are the varied presentations of a bleb. This is the Indiana bleb classification. We have more fields and various other staging systems. So what I've heard is doing trabeculectomy is something like getting into a marriage. So a cataract surgery may be a one night stand or a 1 day affair, depending upon whether you are operating in night or day. But trabeculectomy, you need to stay with the bleb for almost a lifetime. So first step in management of failing trab is recognize failure. Failing blebs are of two types, typical or the encapsulated tenon cyst. Typical failing bleb, these are low to flat, heavily vascularized, no microcysts, causes are tight sutures, internal block of ostia, and incomplete punching. Whereas an encapsulated tenon cyst that is highly elevated, is smooth domed, so a bleb which was avascular, slightly raised, going fine, suddenly in 1 month it is becoming highly elevated with large vessels, patent sclerostomy that should be present. So that should be confirmed by gonioscopy. And in tenon cyst, we find something like this photograph. So we find a fibrous ring of steel. So second step in management of failing trabeculectomy is identifying the cause. In this, we determine whether it is an external block or internal block. External block that may be due to episcleral fibrosis or tenon cyst, as just discussed, we need to identify it. Second, identify whether it is an internal block to the ostia by iris vitreous or fibrin. Second, we need to identify other risk factors like young age, males, African race. All these features make the eye more prone to fibrosis. If there has been a pre-existent inflammation like uveitis, trauma, a neovascular glaucoma, history of usage of certain anti-glaucoma medications, particularly prostaglandin analogs, history of previous surgeries, cataract or glaucoma surgery, history of bleb failure in the same or contralateral eye. After this, we move on to the treatment, which means we need to control the rising IOP and try to manage the failing bleb. We do this by different modalities, a combination of different modalities like bleb massage, anti-inflammatory and anti-glaucoma medications. We deal with the sutures. We do bleb needling or bleb revision, and then there is a category of miscellaneous treatment. So coming to digital bleb massage first, this breaks early adhesions, forces aqueous through the patent sclerostomy. How it is done? Easy, just digital pressure through upper or lower lid for 10 to 15 seconds. This should be intermittent, can be taught to a knowledgeable patient. Anti-inflammatory therapy, particularly topical steroids in vascularized blebs, strong steroids like prednisolone, the frequency can be increased. Anti-glaucoma medications can be restarted. Topical aqueous suppressants are preferred. We need to avoid prostaglandin analogs and allergy-causing drugs like briminodin. This is particularly suitable for encapsulated tenon cysts. Coming to the sutures, so we remove the releasable sutures preferably in the by post-operative 3 weeks, although this depends on the eye, the surgeon, and the type of surgery, whether antifibrotic agents were used or not. One suture that should be removed at a time, we all know this, and apical suture has to go the last. Mostly it goes the last. So this is a nice bleb forming after removal of the RS. Laser suture lysis, we all know the settings. Nd:YAG is mostly used. Again, one suture to be lysed at a time. And if this is done within 3 to 6 weeks post-operatively, it's going to fetch better results. That's what is advocated. So this was one of the cases where all 3 sutures have been lysed, fixed sutures, and still we are finding no bleb. It's a flat bleb. So what we resort to? We resort to digital massage. Digital massage, I've specifically put this video because many comprehensive ophthalmologists, they do not do this, or they do it not in a perfect way. So the pressure that should be intermittent, that can be applied through the upper or lower lid. Upper lid is preferred. And here we can see, without any further manuals, just with slight digital massage, speed this up for paucity of time. So that's a very nice bleb. And with Van Herrick, when we are evaluating the AC depth, then we are finding the AC depth is also, AC is also okay in this case. So I hope my slides are still visible because internet connection is weaning off, I think.
Yes, it's visible, Dr. Lippi.
Right.
You continue. Yeah,
I'll just rush through it. So Bleb Needling, this is one of the maneuvers which we do, which is quite often used, especially in case of encapsulated tenon cyst. We need to go through this bent needle all the way through the ostia into the AC. So that is always preferred. This can be done under slit lamp or in OT. Subconjunctival injection of mitomycin C or 5-FU that can be, and that is mostly, that can be undertaken, and that is mostly done associated with this Bleb needling procedure. Next, we have Bleb Revision. I'm not so fond of this. This is mainly I do for hypotonous eye rather than for fixing a failing bleb. Simple, just we dissect the conjunctiva from fibrous tissue, excise the fibrous tissue. A part of conjunctiva is also gonna be excised, and then we resuture the conjunctiva. We can place ologen implant under the conjunctiva and just hope that the bleb might work a bit. Miscellaneous endeavors like tissue plasminogen activator that may be injected subconjunctivally or in AC when blood or fibrin is present. Nd:YAG laser disruption to retract and disrupt membrane in ostia or depth of bleb. This can be tried. This has been tried by me, sometimes successful. TPA I have not used till now. So to conclude, we need to early identify that the bleb is failing. So early identification is important. Second, we need to evaluate the causative factors. Third, we need to discuss the case with the patient, address the cause by a combination of procedures just discussed. And then finally, we need to plan the divorce, go for a second surgery, whether trabeculectomy again, or a valve implant, or Npds. I think that will be discussed by the next speaker. So many a time, we think that we are dealing with an iceberg and we are all ready for it. But what we don't know at times, that it is only the tip of the iceberg that we are seeing. Thank you for having me. I stop sharing my content.
Thank you. Thank you very much, Dr. Chakravarti. And may I please invite Dr. Cyrus Mehta?
Yeah.
Thank you. He's going to talk to us on combo NPDS and TRAB for better long-term IOP control. Dr. Cyrus?
Hi.
Hi.
Let me share it now. Has it come?
Yeah.
And can you hear me?
We can hear you.
All right. So I've been doing this, those who know me, I've been doing this NPDS for better part of 20 years now. I started doing this in 2000, and there were some issues with the surgery when I was learning it, etc. And the most important issue was long-term IOP control. We know that deep sclerectomy is here to stay. It gives good IOP control and has a good safety profile. You have to choose your cases though. Let's have a look at a very basic video. So this is my basic procedure. If there's not enough exposure of the superior area of the eye where you want to do the surgery, then I just use a corneal bridle suture like this. I was never a fan of a superior rectus stitch, and I was never really very good at it because I never learned ECC. So you do a superficial flap just like you would for any glaucoma surgery, and take the superficial flap into clear cornea using whatever dissecting method that you like, whether it's 15 number or an old cataract dissector like this. That's your deep flap dissection at about 90% depth. The idea being to open up that Schlemm's canal area ahead of the scleral spur. So that's it, it's open there. And with deep cerectomy, the main issue was that people would go too superficial. And then what would happen was that the next day the IOP would be exactly the same as it was before the surgery, and the surgery got a bad name. And that's because they didn't know the anatomical landmarks properly. And if it's not flowing at the time of surgery, it's not going to miraculously start working the next day. So in case this kind of situation arises where you have dissected correctly, then you should peel the membrane. That's a trabecular meshwork you're peeling there. And then if there's still not enough flow, well, then you peel it again, or then you have to convert to a trab. In case you do a double peeling and there's still no flow, it's not going to be working the next day just like that. So you see there's still some trabecular meshwork tissue there. So peel it all off. And once the deceased meshwork is peeled off, you should get a decent amount of flow. And we got good flow like this, and these patients would get pretty decent IOP control. Now and then, just like we saw in the last talk, Bleb would fail and would need Bleb revision and stuff like that. I mean, long-term IOP control was always an issue with this. This most often than not required YAG revision to blast a hole through the trabecular decimates membrane. And if you didn't have experience with using a YAG and a 3-mirror like this, then it would be really an issue for most people. So this was the simple surgery. The issue was long-term success rate and sometimes needs YAG revision. So who's a candidate for a combined NPDS trab? Younger patients under 50, I would not do a pure NPDS because they would be doomed to failure, especially if you didn't use mitomycin C. Patients who needed IOP in the low teens, again, I would not do a deep cerectomy. And those people had intolerance to medication, which is why they underwent surgery in the first place, because most of the time you could not get the patient off medication altogether. So when I was talking with Andre Mahmood a few years ago, he said, do you know that I do a deep cerectomy and now I do an iridectomy also? But I said, isn't that a trab? That's what we were doing since 1969 anyway. So he said, well, not really, because you are removing the deep sclera. You are increasing uveoscleral outflow as well. So he said, you try it out, you give it a go. Since 2 or 3 years, I've been doing this now. So here's your superficial flap again. You all can hear me?
Yes, sir, you're heard.
Yes.
Yes, yes.
Yeah, thank you. Then that's the superficial flap dissection. That's the deep flap dissection. So once you do a DS like this, there's decent flow. But now this is a young patient, and I wanted an IOP of 12, which you are not going to get with a DS. There's your iridectomy. You convert it like this. And single apical suture. I never understood what was the point of putting multiple sutures and then having to YAG them. So always put a single suture, and that always worked for me. And it's the same 8-O vicryl that I've been using for years together. One suture did everything. It did the corneal bridle, it did conjunctival closure and flap closure. So this was a combined NPDS trabeculectomy, which I've been doing since about 3 years now, and it gives me much better long-term IOP control than a pure NPDS. And I think I haven't gone over 8 minutes. So thank you very much for having me, and wonderful to be here. Yeah.
So I think this was a wonderful session. So all our talks are over. So I think Dr. Nangia, if you want to give some take-home messages from collectively, because we don't have any questions. If there are any question from the audience, we have 5 minutes. Doctor.
You are muted, sir.
Can't hear. We can't hear.
Vinay sir, you are muted.
Dr. Nangia.
Yeah, you can hear me now.
Yeah.
So I think that, Dr. Gunjan Deshpande gave a talk on OCT in glaucoma, and all of us know the increasing importance and the need to take a look at the retinal nerve fiber layer and the ganglion cell layer. But most importantly, please try and take a look that the segmentation in the patients and your centration is appropriate, actually. I think that's very important. For Dr. Mayev, that was a very interesting talk also, because, he clearly said that formulas don't work, and it's often just your clinical expertise with low corneal thickness and, high corneal thickness that sort of puts things into perspective. But there was one slide, if I'm not mistaken, where he said that those patients with a corneal thickness of 555 were 3 times more predisposed to those that had a corneal thickness of more than 580. But this may not be completely in tune with what we find here, because the average corneal thickness in India is roughly between 514 to 520, the mean thickness. So this may not so that this may not really fit in with what we're doing, but nevertheless I think these are all important concepts. And also that when you have patients with low corneal thickness, while in spite of what the literature says, I've never been able to convince myself that just because you have low corneal thickness that you're more predisposed to glaucoma. But I have been able to convince myself that patients with low corneal thickness, because of the low intraocular pressure that we measure, tend to get missed out, actually. So that is something that, I think most studies will tell us. And I think for the newer medication that Dr. Swapnil Kothari spoke about, I think that was so exciting that, with one injection, maybe for 6 months or 12 months, you may be able to get, intraocular pressure that may help the patient significantly. And thank you, Ashish, also for your talk on Rho kinase inhibitors, as all of us begin to understand what it's really doing to not only to glaucoma, but also to the cornea. And I think Dr. Lipi Chakrabarti spoke about the management of failing. That's really, I sense that that's a 2-hour lecture that, because it's so vast. But I think that one important thing I'd like to tell you, that although I got trained in massaging eyes from below, but for many, almost 2 decades now, we only massage from the top, actually. And we do that because you can actually see under the slit lamp what is happening. On another note of caution, I do recommend that on the slit lamp, try not to actually do a needling, because the control over needling that you need, because not all conjunctivas are thin, they're not transparent, you're not able to really see where the needle is going. It's often a blind or a partially blind procedure to get the edge of the flap to go underneath to scrape that space over there. So I think please be cautious about that. And thank you also, Dr. Saris Mehta, for this thing. And although I've not been able to understand why you get better intraocular pressure control by doing the surgery along with trabeculectomy, but maybe that the debulking of a deeper scleral flap creates more space, because remember that most of the failures in glaucoma occur not because there is conjunctival fibrosis, but because there is closure of the scleral flap, actually. So I think that more work is required to concentrate on getting the fluid out through the edges of the scleral flap under the conjunctiva. If we do that, then the conjunctiva has less reason to actually close up. So I'd just like to thank you also for having me, because I thought there were so many youngsters. And so I think it's a great honor to be with all of you and to connect with you. Thank you all very much. Shifali, thank you so much. And Manish also. Actually.
So thank you, Dr. Nangia, and all the speakers. It was a wonderful session. And I think now we should hand over to our next session, because it's time now. So good morning, sir. Good morning, Dr. Lani, sir.
Thank you, Dr. Nangia. Thank you, Saipali. Thank you, Cyrus.
Thank you, sir.
Thank you, sir.
Thank you, Lani.
You minded up the session very well, sir.
Thank you.
Thank you. Have a nice day.
It was very good. Can go for the next session. Thank you very much.
Thank you so much.
Thank you.
Bye, sir. Thank you.
Bye.
This video. This is just to show you that even if not is possible.